Thank you for coming today. Very excited to be sharing with you on what we've been working on to help tackle non-adherence at the point of care. So just a little bit of background on the overall non-adherence problem in our healthcare ecosystem. I mean, it's a big problem. CDC call it a national epidemic, right? It's costing us an upward of $300 billion on an annual basis. And it's, as a result in 20% or more of our employers' healthcare costs. I mean, that's huge, right? I mean, it's what it boils down to is when you are not in adherence with your medications and you become ill and you end up not going to work, I mean, that's part of the cost to the employers here. And the one statistic here is very interesting is 50% or more of the patients do not take their medication as prescribed. I mean, that's huge, right? And I was talking to some physicians earlier from my earlier panel. I mean, it's a known big problem. And some of the pharmacists I spoke to, echo these issues. So what we're trying to do is we've been at this for about a year now trying to get this new solution in the market. And very excited to have you here today to share it with you. So a little bit more background on where this problem is today, right? So is non-adherence is just merely part of this larger medications management problem. The gaps in care of today are not identified and properly addressed. And that's lacking the data points that you really need to effectively managing that overall medication management with your patients while they're there, right? So going back to the medication history, that's the challenge that we spoke to earlier. The informations are flowing down from the PBM today and the payer. However, it is very ineffective, and that is because they are faxing and mailing these communications to the point of care provider. And the challenge with that is when you receive the piece of paper, you read it, the patient is not there, what do? You're busy, and it's get tossed, right? It's going somewhere in the corner of your desk, and when the patient shows up for a visit, it's just never timely when you need that piece of information while the patient's in the office. So the third big things here is the CMS star rating suffers from this non-adherence problem. And what this means is at the end of the day, it's impact how the PBM gets paid, right? Because the CMS star rating is low, then the PBM, it does impact their overall bottom line, right? So it's with this application that we're putting in the market will help improve the star rating, and that by doing that at the point of care, helping the physician with the right information to have that dialogue with the patients, and therefore driving up the adherence score for that patient. So some of the challenges today from a user perspective, right? So the PBM, as I mentioned earlier, they do have the information, but they can't get it to the point of care at the right time while the patient is there with the physicians. From a physician standpoint, the pain points are the biggest one is, hey, I have the patients in my office, but I don't have that readily data point so I can have this meaningful dialogue with my patient. Right, so that's the biggest challenge. So think of it as like if you were to manage a patient that have a chronic condition. Let's say I'm a diabetic patient and I'm in your office, I'm on 3 different meds for diabetes, and you don't have the latest and greatest information in front of you, and trying to have that meaningful dialogue with the patient is very, very difficult. Right, I mean, you're aware of what you last prescribed them, but based on what they told you, rather than have real data that they picked up medication from the pharmacy based on the past refills, it's hard to have that meaningful conversation. Say, I see that your overall score adherence for diabetes is this number, and you're telling me that you've been taking it, but the score is not correlating to what you're telling me, right? So that's what we're trying to do is here to arm the provider with the right amount of data, so that you have that meaningful dialogue with a patient. So, when we, going back months back, when we were looking at doing this solution, right, we're looking at how we position ourselves in this marketplace to bring a solution to the market, to the marketplace for that provider that is meaningful for them. And we're well positioned to bring a solution to the market to help address this problem, right? From a standpoint of the the number of prescription records that we're dealing with today, with the PBM, with insurers, the reach that we're able to provide is very large. The number of transactions we deliver nationwide over our network, we already have the infrastructure in place that we can do this. So to bring these applications on top of that, we have the foundation to support this additional capabilities. And lastly, we're working with over 700 EHR applications today. So we're well positioned to bring a new capability to the market to help combat a big problem in the area of medication non-adherence. So we think that we have a solution to help you tackle this non-adherence today. And we can do that by help improve the patient medication management directly at the point of care. And when we can do so via the adherence summaries. Later on, I'm going to go through a product demo to show you what that could look like. So the adherence summary is essentially we take the adherence score that roll up to a particular disease classification. So for example, initially when we released this product in July, the 3 disease classifications we're going to focus on are diabetes, hypertension, and cholesterol. Right? Those are the 3 top ones that we gather from the PBM and also from working with physicians. Those are top 3 that we're going to focus on. And then we can do this and make a difference by making sure that the communications from the PBM and the health plans gets to the point of care at the right time, right? It's, as I mentioned earlier today, it is being faxed, it is being mailed, and it's inefficient. So we're going to make sure that this capability to allow the PBM and the payers to communicate directly to the physicians at the point of care via an electronic messaging, right? Now I'll show you the example of what those communications look like today and going forward. Okay. Just some high-level, value propositions why this is important for all the parties that's involved in this spectrum of care. So think of it as, from the far end, we have the PBM and the payers. For them, give them a chance to improve adherence and gaps in care program. That is the biggest one today, right? They are sending down these informations, but they're not getting anything back. There's no feedback. It's more of a one-way communication, and they don't get back the valuable feedback from the point of care provider because it's done by fax and mail. So when they read a piece of paper, they don't know how to provide the feedback to the PBM. Financial savings on direct variable cost. Right, it costs money for them to mail the paper today, for them to fax the paper today. So this application, the capability will help reduce that variable cost tremendously. And thirdly is to help improve the quality and star ratings, and this will impact their bottom line. Right, the higher the star rating goes up, the better it is. They will get paid. From the EHR standpoint. What this is, we interview a lot of physicians in the last year or so. We done, internal research, and we also use external research companies, and they went out and talked to physicians, and there is a need for this application, right? They're asking for it. So we want to use this, we want to have this capability, and the question is when we're done with the research is when can you have this in the market, because I can use this today. So there's definitely a physician's demand. From an EHR standpoint, you can differentiate yourself with this application capability by directly integrate this applications within your own workflow, right? So the idea here is when we put this in the market, you can take these applications, its capabilities, and integrate it seamlessly into your workflow. So you're not going to launch a different window. You're not going to go to a different tab. Surescript, we're going to pass you all the pertinent data points. You can either take the data points and render within your own environment, in a case where you want to have full control of your UI, or you can do a hybrid where you can take some of our UI services and display it in your own environment. But we're going to have to make sure that we work this so that it's seamlessly integrate within your workflow, so it has the look and feel of your EHR environment. And it's thirdly, it's going to help drive up efficiencies. So today, think about how the doctor is handling this today. When they get communications from the PBM, is paper, right? You said earlier you were busy, right? Think about if on average, if you see 15 patients a day and you get more, then just use number 15, and you get on average 3 message communications per patient. That's 45 things that you have to view in that day, right? And on average, 3 minutes times 45, it adds up. You're running out of time the day, right? So with our applications and its capabilities, you can now see that from directly inside that patient's chart. So while the patient is sitting there, you have the information in front of you. You can view it while you're seeing that patient, and you can reply back to the PBM directly in real time, right? So that's a win-win, right? And there's a revenue share opportunity, right? So we depends on the business model, but they're over, from a high level, to encourage physician adoptions, there is a component of revenue opportunity for the EHR. So what does this mean for physicians, right? I think the biggest thing here is to allow you the time back to provide better care for your physicians, for your patients as a physician, in the area of informed care, and to drive up efficiency, right? Time is valuable, and you need all that time back to have that time to care for your patient, to have that meaningful dialogue with your patient. Reduce alert fatigue. This is huge, right? This is a hot topic in the physician's world. I was told earlier that doctors are very set in their ways of doing things. So if you're going to introduce something new, it better be simple. It better be quick and easy. Otherwise, they're going to not like it, and they're not going to adopt it. So fully aware of that. We heard it. We done over 140 so physicians interviews, one-on-one interviews. And the message at the end of the day is, don't make it complicated, right? Just make it simple so we can use it. And if you're going to ask me to do something extra, to click on a window and open up a new window, forget it. I'm not going to use it, right? So fully aware of that. Improve your quality, public quality rating. Basically, this is in the area of address gaps in care, right? With this product, you can now see the latest and greatest information for that patient regarding their adherence, and you can now address that, that gaps in care and go right at the point of care. Okay. This is more of a marketing sales pitch on how we can connect to the various players in the market. So our solution is developing based on the latest standards, FHIR standard technology. The idea with that is we want you to be able to take this product and its capability, implement it within your own environment quickly, and get to the market in a timely manner, right? So traditional implementations could last anywhere between 3 to 6 to 9 months. The idea here with this application is we want you to get there in the market in less than 3 months, right? So we're adopting a FHIR standard for both on the front end between the PBM and Surescripts, and also on the back end between Surescripts and the EHR. Okay. A little bit on the high level flow of how our solution works. I'm sorry? There's a question.
How is the definition of adherence?
So the question is, how are we defining adherence, right? So adherence is Adherence is sometimes get confused with compliance, right? Adherence here, the way is defined and calculated is, let's say I'm on 3 medications for diabetes, and I am picking it up and taking it as prescribed and get my refill every 30 days. If I do so, then my ideal perfect score would be 80%, would be 100% because I'm adhering to what being prescribed. I'm taking it, I'm getting my refill, continuing to take my medication. So from a PPM perspective, when they sent over the overall adherence score, it is calculated and is sent over in a numerical format in a percentage. So it's based on the number of fill days. It's based on your when you pick up your medication. So they take all those data points and calculate and give us a number that we can display at the point of care. So for someone, let's say, that have 80% or better, that's considered clinically beneficial when they're on that particular therapeutic, class or medication. So 80% or more is considered clinically beneficial and is considered good. Anything between 60% and 79% is considered, in that zone that the physician should be aware that you're adhering, but not all the time. And then anything fall below 60% is when you're consider a high risk, right? And we're going to flag it with the color of red, and I'll show you via product demo when we go through that, and it's give you a quick visual indicator whether or not the patient is in adherence to their medications or not, right?
Good. I'm glad somebody asked the question. I'm Mike Miro from Indiana. I'm a cardiovascular specialist who is an informaticist. So adherence, you're using claims data from the PBM, right?
Correct.
Yeah. So what we were trying to do at our health system is get a Surescripts feed to have a feedback loop to our enterprise EHR very quickly so we could timely notify patients if they didn't go to the pharmacy and pick up their meds. But as far as I can tell, no one's done that with your system. So how could we solve that? How could we get a Surescripts feed to tell us, are you dependent on the pharmacy to ping you back or something?
Yeah,
yeah.
We are.
So
yep.
if the pharmacy is non-compliant,
Then,
in other words, right?
Yeah.
Right.
Yeah.
So why can't that be done electronically where patient picks up their meds, it's e-prescribed, you have no problem, and then the problem is getting the data back that they picked it up. So
yeah,
you're dependent on their data because claims data, the clinicians, I can tell you right now, we get these reports from Anthem and the different payers saying,
right.
Of your patient population, only 60% are adherent. Well, that's based on claims data, which is there's all kinds of attribution problems and et cetera. But
True.
if we could get a feed for that patient specifically, we could message them through their PHR and tell them that they're that they need to get their meds filled.
So who are you trying to message? Are you trying to message
a patient?
A patient.
I'm trying to message patients. So 30 to 40% of patients with multiple comorbidities like heart failure, diabetes, are non-compliant. And to what you alluded to what degree? So the people that are really non-compliant, their outcomes are poor, and so all this population health is very dependent on the patient taking their meds.
Correct.
Yeah. So then the outcomes are bad. So this is probably the most critical thing in population health management is to get the patients to take their meds. So hypertension, diabetes, heart failure. Yeah.
Yep.
So anyway, this is I don't want to, but that's my question: is how could we get a feed from Surescripts back to Epic, for example? That's what we have. And to solve this problem.
Yeah. So great question. Thank you, by the way. We just now getting started with this application's capability. Totally understand where you're coming from, where you're going. I think that's definitely something that's doable. Just a matter of question is timing. A little bit more on that question though, because when you say you want to message the patient, what does that mean? Are you sending them a text message reminder? Are you sending them an email via a portal? Right. So that's another point of integration implementation that we need to worry about. As far as getting the feed directly from the pharmacy, it's doable, but it's so let me continue on this because there's one component in here I think it will address the short-term concern of what you're talking about from the standpoint of the patient is not picking up their meds. So there is a communication directly from the PBM about missing medication, right? So so when the patient is not picking that up, they will, the PBM will know, and that message will get kicked out right away, and it's going to get all the way over to the point of care, and the physician will know about it. Now, what do? They can either call the patient or they can wait for the patient to come in the office while they're there for a visit and talk about, hey, you're supposed to be on this med, but you're not. Did you forget to pick it up, or did I, what's going on here? But to take it further to your point about contacting the patient directly, that's an additional part of the workflow that we're not addressing in this initial version of the product.
I was just going to say also, though, we have a session that we talk about the data feed that
Yep.
we will, it's basically our medication history for panel management. It's not this session, it's another session. So let me connect with you later and give you the time on that, because we do have basically a data feed that we'll be providing to you around the real-time data from pharmacies.
Thank you,
The
Mary.
reason it's important, the timeliness. So, for example, anticoagulation for atrial fibrillation. If the patient misses, like, just a day of medication, they have a stroke. Yeah, and I've actually seen that. So, just stopping their meds for a day, these newer anticoagulants,
Yeah.
is a disaster. So,
Yeah. Thank you. Thanks, Mary. So just to get back up this high-level flow, how the communication is going to get done from the PBM all the way down to point of care. So on the top there, on top left, where you see portion of days cover ratio, this is in regard to the PDC adherence ratio. So what the PBMs do is they take all the meds that roll up to a particular disease class and they calculate based on historical data, turn into a summary score, and send that over to Surescripts, and then we can turn around and make sure that it gets to the endpoint based on a certain number of business rules, whether we send it right away or we send it while the patient's in the office. The real-time messages here, you see here, this is the actual text communications from the PBM. So the initial communications that we'll be focusing on are in the area of high-risk medication, adherence message, and also missing medication. So if a patient, let's say a patient 65 years and older is, have high cholesterol and on a med that they shouldn't be on, or could have bad side effect, the PBM can then turn around and say, hey, listen, Justin is 67, he's over 65, he's on glyburide, and you might want to consider put him on an alternative, right? So that communication is now in real time, and it will get directly to the point of care while I'm there or while I'm not there. In a case where it's high-risk medication, the PBM will have a chance to make sure that that message get directly into the physician inbox. It's going to be part of a different workflow so that they can act on it right away. And the rest of the messages, like the adherence message and the missing medication, those are considered non-urgent, and they can be viewed during the patient's visit. That will be available within the patient's chart, right? So over here in the upper right is basically how we get it over to the endpoint. The one big thing here on the bottom I want to point out is this provided feedback. That is the loop that is missing today, right? That is non-existent today. The only way that a physician can reply back to what they get from the PBM when they receive that piece of fax or that piece of mail is for somebody to pick up the phone and call that helpline. So going back to my point earlier about not having the time, and you see in 15 patients a day and you have these communications coming down, you just don't have that time of day to do it, right? And just very inefficient, and sometimes it's out of sync. And if you get a nurse to go make that call, and you get a nurse to call that patient, and then when that patient showed up, everything is just out of sync. So this provider responses now is when they see that message from the PBM, they can provide real-time response back to that PBM. Say, hey, I saw your message. You can say whether it's useful, or you can provide your own text. When I go through a product demo, you get a flavor of what it looks like from a provider response standpoint. My next 3 screens are basically static screenshots. Let me go through an actual product demo. It will make a lot more sense for you. Okay. So this product is designed, think of it as have 2 different views. One of it is for a physician view, we call it provider context, and the other one is a patient context, is meaning when a patient shows up for an office visit, that patient sits in front of a doctor with their electronic medical record opens in front of the doctor. What you see here is a provider context. So in the case where there's urgent messages, in this case is high-risk medication messages, it will go directly into that physician inbox or a work list, right? There's a designated area within that workflow for urgent items that these messages need to land in. Yes, sir.
That's an enterprise EHR. It's not a separate portal. That's in a hypothetical enterprise EHR, not a portal.
This is an example mock-up of what it could look like in an enterprise EHR.
Okay.
It is not a portal. To my point earlier is about seamless integration. Is we will take this capability, integrate it into an EHR workflow, so that let's say if you Epic and on the left-hand side you have the message coming in or alerts coming in, these alerts will appear on the left-hand side. So there's not a portal you need to go to or a separate web page you need to launch.
Yeah.
Yeah.
Because that's a non-starter.
Yeah. It's trust me, I'm fully aware of that. So, let's take an example. Let's take a look to see what one of these messages look like. All right. So this is, from the previous screen showed you the high-level notifications like, hey, you have something you need to look at, and you click on it to view the message. And what you see here is an example of high-risk medication for Renee. And the highlighted blue is an actual language, actual communications comes from the PBM, right? I heard a comment earlier before these sessions about the amount of text. It needs to be just right. It can't be too long. So we work very hard with the PBM to make sure that we are concise with how the language is coming across and get communicated. After you get a chance to read the message, you have a chance to respond. And this is what I mean by provided response, right? When you read that message, you now have a chance to reply that feedback directly to the PBM. So in the case if you say yes, let's say if you change this patient drug therapy and you click on yes, you can, as soon as you hit the submit button, it will go directly back to the PBM. Or if you decide to provide some additional text, free form text, you can do so as well. Yes. Yes. So in the case of if there's an alternative suggestions from the PBM, it will display in that text up there. It will say alternative : and then the additional name of medications that they think that patients should be on.
And from a provider's perspective, it would be very nice.
We've been recorded.
From a provider perspective, it would be very nice if that had a NDC number attached to it.
Yes. Yes. Yeah, so we went down the design path of not including NDC, and on my last round of physician interviews, and I displayed the overall adherence medications tab. I'll show you what it looks like. See this right here? So in this case, Renee is taking diabeta for diabetes, and her overall score is 71%. And what, to your point, Cephas, is the NDC. That's very important because the name could get messed up. But with that NDC, are you talking about a representative NDC, or do you have a preference?
The point is that if it's going to be fast, if there is a medication which might be selected otherwise,
Yep.
I don't want to have to type that in.
Yeah. So
So if there's a recommendation medication in this script, it has to be easy to put in. Otherwise, I won't do it.
yeah. Thank you. So the NDC would be somewhere over here with a suggested alternative. And let me show you what it looks like when you click on no to response back. So if you decide not to change the drug therapy for whatever reason, and the PBM would like to know why, you know, these are some of the thought out and preset responses that you can reply back to the PBM. One other thing we do here, if you don't see a listed reason, you can click that and provide your own feedback of why you think it's a certain way, right? So that's provider context. Okay, let's go into the patient context and see what it looks like. So don't mind this screen here. This is typically a screen where you drill down and you pick the right patient. So for the purpose demo, just want to let you know that so you won't get confused. So I'm going to pick Gail. Again, this is a mock-up demo, so you can ignore the surrounding area where it says medication management. We just try and simulate what an EHR environment could look like. So the area I highlight in blue here, if you, from within your own EHR, when you open up that patient's chart, you will have this summary screen somewhere. It's going to be entirely up to the HR how to render information to have this summary level, right? The idea here is to give you that snapshot of, hey, are there any messages waiting for that patient for me to view? What is their overall adherence score, right? And oh, by the way, we're gonna highlight what that overall adherence score is in that a particular disease classification. The logic behind this at a glance view for the adherence score is we take, let's say if I'm a patient that have 3 disease classifications, diabetes, cholesterol, hypertension, and I get 3 numbers sent over from PBM, I will use the lowest ratio, and I will turn this screen to a certain color to make sure you as a physician aware that, hey, Justin is, you know, he has one of the condition he's not doing well on, and I need to do something about it. Let me go in, you know, let me go in deeper so I can have that conversation with Justin, right? So in this case for Gail, there is one message waiting to be viewed, and it's high-risk medication. And again, here's the language, right? This is standardized language, by the way, and you can respond. And here's Gail's medications for diabetes. She's on 2, and her overall adherence score for diabetes is 79%. So she's doing good. If you were to go, let me see here. If you don't want to read that message right away and you want to see what's really behind that med adherence, you can click on that tab to get the underlying information for that particular disease classification. So what you see here is, again, this is our sample mock-up of the UI. From an implementation standpoint, you have flexibility of how you can absorb the data points, the structured data elements. You can do simple things like a web API call, and we can hand you all the structured data elements. And from within your own environment, you can take those in and render based on how you want to display in your own UI. Okay?
What are the drug codes that you're moving back and forth? I mean, are you using RxNorm or NDC or?
NDC, yeah.
So
Thank
you
you.
have to map it up?
Yep. Yeah. And then the nice thing with including NDC is, you know, for you, from EHR standpoint, if you want to run a report, right? And that's one nice way to correlate the NDC within the report. With just the drug name, it's hard to you know, because sometimes the drug, you know, whether you go with a generic or a brand name, it can get complicated. With an NDC, you can make sure that you're getting the right amount of information. Okay. Let me pick another one here. I want to show you one with multiple disease classification. Here's a person is not doing really well and not doing well at all in hypertension. Right. So this example, let's give you this person is taking medication for cholesterol and hypertension, and they're not doing so well in hypertension, right? And then in cholesterol, she's doing pretty well. So as we add more of the disease classification, is just this table is going to expand, right? So okay. All right, so let me wrap this up. So, what we're trying to do here is give you as a provider at the point of care, a tool that embedded within your own workflow. Not, you don't have to go anywhere to go to a portal. A set of tools that give you enough information that you can proactively manage that patient medication regimen. And the final outcome here is to drive up that patient's overall adherence score, right? Is from a patient standpoint, we want to make sure that they're healthy, they have a better outcome for their overall health. From a doctor standpoint, we want to make sure that you have the right information at the right time, and is embedded directly within your workflow. If you are a PBM, we now have a tool that you can effectively getting the communication that you want to the point of care in a timely fashion. And you are now part of that, more of a aware network, right? So if you have this capability and the PBM have information that need to communicate with you as a provider, you are now part of that more aware network, and you can now proactively managing that patient's overall medication regimen. Okay. From a timing perspective, we are launching this product in July. We have a national PBM participating Prime Therapeutic, and the two EHR that we're working with right now are the MedConnect of Alabama and Augusta of North Carolina. And the health plan we're working with is the Blue Cross Blue Shield of those 3 states. So the states are Alabama, Florida, and North Carolina. And our plan is to have this product generally available to the public at the end of this year, or maybe even sooner. Okay. With that, I'm going to stop for any questions. Are there any other questions? Okay. Well, thank you.